Dr. Bailey joins. Welcome, everyone. We're going to be talking about the future of the Tennessee Heart Health Network. There's some exciting news. I know there's some new opportunities that have been, recently been granted. And so I know, Dr. Bailey's going to be talking about some of those things when he joins. Are there any, Ashley, Nikki, are there any announcements or anything that you want to cover while we have a few minutes?
No, other than, we're filling out the calendar between now and the end of March. And if you get our newsletter, we'll always have a calendar of the learning collaboratives for that month and the next month. So if you don't get the Tennessee Heart Health Network newsletter and you would like to, please leave your contact information, your email address in the chat. Thanks.
Perfect. Thank you. All right. We'll just give it just a few more minutes. Dr. Bailey may be on another call.
Yeah, we actually were on another call with the CDC. We're probably still in conversations with them.
Thank you for letting us know.
You're welcome.
Is that you, ASOS?
You're welcome.
And also, we sent out a press release this week about our $6 million grant from CDC. So let me get the link to that and put it in the chat. So if you haven't seen that press release, you can take a look. It's also posted on our website.
My apologies for joining a little late. I had trouble with Teams, but I'm on board now and glad to be here.
We know Teams does not play well in the sandbox with Zoom.
Well, not all the time.
It doesn't like it. Well, we're glad you joined. We knew you were on another meeting and you were trying desperately to move over. So welcome. I know you've been traveling this week and had all kinds of adventures. So many of you that are on the call, you've met and collaborated quite a bit with Dr. Jim Bailey. He's head of the Tennessee Heart Health Network. And Dr. Bailey, I'm just going to let you take it away.
Excellent. Excellent. Well, I'm really glad to have this opportunity to do this update, and I really have questions, a lot of questions for the group as we go through about where you are in this process and what our next steps should be together, because I think that'll be largely driven by what our practices and our providers want to see. And I wonder if we, I'm just looking at who's on the call. I see, I don't know if we have time to do some really brief introductions. Would that be okay? I think I know the UT team that's on here, so I just wanted to go around the room for the people who are on my sidebar. Starting out, could you introduce yourself, Asos Mahmood?
Yeah, sure. Hi, everyone. My name is Asos Mahmood. I'm an assistant professor at the College of Medicine, UTHSC. I'm also the director of Population Health Research Education for the Tennessee Population Health Consortium.
And Jill Jones, would you mind introducing yourself?
Sure. Jill Jones, AVP of Clinical Services at Ballad Health. I work with our ambulatory health improvement team, and we provide a vast array of services for our patients in the community at home, as well as support our practices.
Fantastic, fantastic. And I saw Dr. Paul Perriman. Paul, do you want to introduce yourself briefly?
Eating lunch. So yeah, just jumping in for a minute.
Paul is in Columbia, Tennessee, and
Yeah, solo
has
practice,
been,
right?
really bringing the voice forward of the solo practitioner. You know, we've been so thankful for your participation, Paul.
Thank you.
And I see next I'm looking Jennifer Logan.
Hi, can you all hear me? I'm not sure if my speakers are working.
Yeah, we do.
Jennifer Logan with ETSU Health. I'm the Director of Population Health here. And we work with all of our value-based care arrangements and do all of our reporting for PCMH and macro and all of that sort of thing. And I think Carolyn Bailey is also on the phone, and she's on my team as well.
Excellent, and she's one of my distant cousins. So welcome, Carolyn. And Mary D, can you introduce yourself?
I sure can. Can you see me and hear me?
We don't, you're dark and your voice is really soft, but we can hear you.
Okay, how's this?
Better.
Okay, good. So Mary DiGiulio, I'm a family medicine physician here at Erlanger East Primary Care, and that's on the east side of Chattanooga.
Fantastic. Thank you so much for being here. And Jonathan, I think that's maybe Jonathan Hughes. Jonathan, can you introduce yourself?
Hey, this is Jonathan Hughes. I apologize for having my camera off, just grabbing some lunch real quick. I'm calling in from Ascension Medical Group, Tennessee, specifically the St. Louis Family Medicine Center in Murfreesboro, and I'm our clinic pharmacist.
Excellent. And the last person I'm gonna pick on briefly is Adrice Williams. Adrice, can you introduce yourself?
I'm Adrice Williams. I am the Director of Care Coordination at Christ Community Health Services.
Thank you so much for being here, Adrice. Really appreciate your attendance. And, you know, most of the other people on the call are people from the UT team, and we can all wave, or the QSource team. But we really appreciate, you know, the people across Tennessee, the people that are on this call that have contributed to these discussions and making them fruitful and valuable as we think together about how we can improve heart health care across the state. And I'm going to go ahead and share my slides. You know, academic types have a hard time talking without slides. So I'll share my screen and bring up my slides here. And our subject today is the future of, and I'm going to see, can y'all see my slides now?
Yes.
We can.
Excellent. Is the future of the Tennessee Heart Health Network, what's next? And in large part, the future of the Tennessee Heart Health Network, we're going to do our best in our work going forward to support and provide educational content, learning collaboratives, and other tools and opportunities over the next several years to support your efforts to improve care. You know, we're intensely aware that the real work in this project is the boots in the ground work that you and your teams are doing. And so we're very desirous for your input and your guidance on how UT Health Science Center and our other partners in this effort can help one another. And so that's what I'm going to be talking about today, and some of our thoughts about next steps. And I'll try and punctuate that with a few questions for you guys. Okay, let me see if I can advance my slides. There we go. This is our broad mission. You know, it's a very broad and ambitious mission, but at one level, it's really simple. You know, we're out there in our practices across the state working hard to better control high blood pressure, to prevent and reverse diabetes, reduce strokes and heart attacks. And ultimately, as our Chancellor Buckley at UT Health Science Center has said, we need to work together to improve Tennessee's composite health ranking. So that's all bold and ambitious, but of course the question is how? You know, what can we do in primary care to make a little difference? The underlying all of our work is this horrible pandemic of obesity, which in my mind drives everything that we're struggling with. You know, the huge epidemic of chronic illnesses, hypertension, diabetes, and all the consequences of those chronic illnesses. But ultimately, it has its roots, this plague of chronic disease, in the pandemic of obesity. And so we're trying, you know, a lot of our work has been to try and get better at moving up at addressing factors around healthy eating, overweight, obesity, physical activity, and doing more to promote those in our practices, which, as we all know, is not easy in the press of acute illness care. So we've had a lot of discussions over the last several years about what we can do to get at some of the underlying causes driving the obesity epidemic, which of course is all about access to food insecurity, which, you know, right now, thus far with the Heart Health Network, we haven't done much to get at these root causes, but we're at least aware that, you know, it would be good if we could move upstream to address some of our social needs that are actually driving the obesity epidemic and the epidemic of chronic disease. But in the busyness of everyday practice, it seems there's scarce time to address some of these broader underlying issues. So I'm going to start by just going through a little bit of what we've been doing over the last 2 years and this third year of our project to build capacity through the Heart Health Network to support your work a little better and help us move the needle on blood pressure control, diabetes control, delivery of smoking cessation counseling. And I'm going to talk first a little bit about what we're going to do to continue that work over the next several years, and then where we're going to go beyond that. So, you know, as most of you know, UT's work in this has been supported by the Agency for Healthcare Research and Quality. Well, our grant with the Agency for Healthcare Research and Quality is coming to the main grant period is coming to a close at the end of this year, or actually at the end of February of next year. We do have an extension to continue to analyze data and work on some of the data aspects of this. But the saddest part of this is that we are going to, for the Heart Health Network project, after the end of February, we're not going to have as much assistance from QSource. And we're actually looking at ways we can continue to work with QSource on the Heart Health Network work over the next several years. But that's going to be one of the changes, is that is that QSource may not be quite as involved after the ARC grant ends. But just to kind of review our work that we've been doing through the ARC grant, I want to talk about kind of how it is going to move forward, even without as much support from QSource after February. So as many of you know, we now have 62 primary care practices that have stuck with it, that have really stayed with the Tennessee Heart Health Network effort and have helped us document your experiences in working to change care in your practices, so that we can learn together from, about what practices need to improve heart health care. We got this grant in the first place because we're in rough shape, right? We're leading in one of the leading states in heart attacks and strokes. And through this project, we brought together a lot of tremendous partners across the state. And this doesn't show all of them, but some of our key health system partners across the state. And we've worked in these three areas: primary care workforce development, motivational health, rolling out heart health messages, and pharmacist-physician collaboration. And we set some really ambitious goals for what we might do to expand the presence of community health workers, health coaches in our practices, and deliver motivational heart health messages. So, and this is the way we've worked with the practices. We've provided your practices with some financial incentives, just basically to support your time. We've had these learning collaboratives, and we've offered training for health coaches. And by golly, we've trained about 30 individuals in your practices in motivational interviewing. Some of those individuals are getting certified, but we are still, we haven't made the path entirely clear on payment for health coach services. So, that work with TN-Care and our population health subcommittee is ongoing. But the good news here is that with the TN-Care managed care organizations, we are, within the next 6 months, I predict, going to be sending out FAQs, detailed FAQs on how to bill TN-Care for health coach services. And we expect with this getting out of FAQs and continuing education on how to bill for diabetes prevention program services, for chronic care management services, for weight management services, for smoking cessation counseling. But we're going to be focusing in the next several months and into the new year into continuing to provide guidance on how to get reimbursed for those health coach services. And we are going to continue to support practices that are in the Heart Health Network now in training and deploying health coaches in their practices, because we think increasingly there's going to be a financial case. And, we've had this open deal that we would train up to 2 health coaches in each of our participating practices for free, and that we will train, have them go through our health coach training and certification. That deal is going to stay open. And actually, so if you haven't trained your 2 people, and if you want to train additional people and put them through our health coach training and certification program, we offer half price on that program to any Heart Health Network members, member practices. So we're going to continue to try and make it easy for you to train and deploy health coaches, and hopefully get them reimbursed. So first question I have out to you, and you know, part of what I'm going to be moving into is talking about our new CDC grant that's going to help to support our ongoing work. It has training of and multidisciplinary care using coaches and community health workers is a major focus. So we're going to be continuing to support practices in this arena to the best of our ability over the next 5 years of that CDC funding, which started this end of September. So, so I think this is really good news for our efforts to do workforce development in our practices and bring on more community health workers and/or health coaches to close the gap on care needs. So first, any questions or thoughts about our work in this area? What you think questions about what you'd like to see us do, or what we might do, or what we're able to do. Any questions about or thoughts about how we can better support bringing on board coaches in primary care practices? So Paul, I know you're on the line. What would it take to convince you to actually hire a health coach? Is that something you would ever consider if the reimbursement was right?
I'm sorry, I had to step away to use the restroom, so I missed the last 5 minutes. But my quick answer on that would be it'd have to be paid. I mean,
yeah, it has to have a strong financial case. Yes,
that'd be it.
Yeah. Any of our practice representatives who've had individuals go through the training, any thoughts from you on how you're thinking about using community health workers or health coaches?
So this is Jill from Ballad Health, and we've had 6 go through the program. It was a great program. They learned a lot. We are considering for our health improvement team using health coaches. We haven't gotten there yet. We have to figure out how to get the FTEs to do it. But how we thought about using it was in support of our chronic care management team, where patients with chronic conditions need more hand-holding, and where we could have a nurse who set up the care plan and then have the health coaches support that education for those chronic diseases.
Wow, that sounds great. Would you do what settings would you do that in? Or are you thinking about doing that in?
So that would be our ambulatory setting. So these would be patients that are already discharged home after a hospitalization.
Ah, I see. Yeah, that totally makes sense. I think that's a fabulous place to start. And then you would be using those chronic care management codes in particular.
Hopefully, yes.
Yeah, yeah. And are y'all participating in any of the ACO opportunities that have incentives for you to improve some of those metrics around transitions of care?
Yes. So we are currently participating in MSSP, and then we also have some value-based contracts as well.
Fantastic, fantastic. Well, any thoughts as we move forward on how the Tennessee Heart Health Network, UT Health Science Center can be helpful in your work to get the personnel you need trained and deployed? Any thoughts? Please let us know. Any others who want to comment on anything they're doing in this area around use of community health workers, health coaches? Okay, I'm gonna press ahead. You know about our training programs, and um, for those of you who've worked with Susan Butterworth, and I think we really have some great training opportunities, and we're going to do all we can to make those accessible and a support to what you're doing. If you have suggestions for us on ways to improve what we offer or how it can be interface with the training you're doing on the job, certainly let us know. On the motivational text messages, this effort to deliver motivational heart health messages to your highest risk patients has proven much more difficult just logistically than we thought it was going to be. And the difficulties have been mainly around getting everyone on board with the TN-POPNet, getting their data feed established, and setting and getting the data harmonized so that we can send personalized and tailored text messages to your patients at highest risk. I'm just curious, are any of the practices on the call participating in, well, I know Christ Community is, in Heart Health Messages, in our Heart Health Messages intervention. Anyone want to, well, before I ask for comments, I know Christ Community is, anyone else on the call participating in the, or wanting to still participate in Heart Health Messages? Yeah, I don't think Ballot is doing Heart Health Messages or ETS.
I actually wasn't aware of that. I'm sure there's someone at our organization that is, but I wasn't aware of this.
You have that opportunity. So just to give a quick overview of where we are with Heart Health Messages, we are continuing to offer this product to our participants in the TN-POPNet. And we now, you've heard technically it was more difficulty, we had more difficulty than we anticipated, but we're now rolling out Heart Health Messages at a couple of our health systems. We started with Christ Community Health Services, and Christ Community Health Services, what we've learned is we've really needed to outreach the patients with the service and encourage them to enroll. And Christ Community has been putting up posters in their various practices. They've been handing out flyers, encouraging people to scan the QR code to sign up. The sign up process takes a little while. So that's been the big place where we found that practices really have to work with patients to encourage them to sign up, using flyers, posters, mailings. And so we've started doing that with Christ Community Health Services. We're now we've begun rolling out motivational heart health messages at Regional One Health. We are working to roll out heart health messages next in a couple practices in Middle Tennessee in the Chattanooga area. And so the short answer here, even though Heart Health Messages isn't a major part of the effort going forward with the CDC, it is a service that the Tennessee Heart Health Network is going to continue to offer either below or at cost. And right now, for everyone who's signed up for that intervention, we've pledged to deliver that intervention, even if it's in the second half of next year. So any other practices that are on the call that have an interest or had signed up for this intervention? Okay,
Hi, Dr. Bailey. This is
yes.
Brenda Buckley. I'm with Regional One Health Hollywood Primary Care, and the patients that you're talking about in reference to receiving these calls, how would someone like myself working for Regional One's primary care site, how would I know the patients that I may have that have partnered with Tennessee Heart Health and is receiving these particular type of messages? Is it something that I could ascertain from their records, or how would I know if I had patients in my clinic that were participants?
Oh, that's a great question. Because we have rolled out at the outpatient center, we haven't yet rolled out at Hollywood.
Okay.
What is your, remind me your role at Ms. Buckley?
I
Or
am
Dr.
a practice manager for Hollywood Primary Care, one of
Ah,
Regional One satellite clinics.
yes. So we are eager because Guthrie Clinic closed, and I know, I guess
Correct.
you gained a provider or two from Guthrie. Is that
Right.
right? Yeah.
Mm-hmm.
So we would really love to work with you over the next couple months on planning the rollout at Hollywood, if you would like.
Yes,
Um,
that would be great.
Fantastic. And, because as you've heard, uh, we really have to market the service to patients to get them to sign up. We know if they do sign up, that it actually helps move their behaviors around healthy eating, physical activity, and taking medications correctly.
Mm-hmm.
And they like getting the tailored messages. But to answer your question, so it's text messages, not calls. It's
Okay.
text messages that they
Mm-hmm.
get that have been, vetted and tailored so that they're friendly and patients like them. And what we can do is we can actually provide you a list. First, we'll provide you the number of patients or even a list of patients who are eligible. And
Okay.
then we can, as we send invitation text messages out to patients, and so we can send you the list of the patients you have that qualify, and then we can send you lists of the ones that sign up. And we can send
Okay.
that list to you securely so that it's all HIPAA protected.
Okay.
But does that sound good?
Yes, that does. So I'll just provide you my contact information in the chat. Okay.
That sounds fabulous.
All
That
right.
sounds
Thank you.
fabulous. So long and short, we're committed for practices that are interested in having their patients have access to this service to continue to deliver that. And then lastly, pharmacist-physician collaboration. Ashley Ellis is on the call. She's been our point person with the College of Pharmacy for this effort, along with Carolyn Dowling at ETSU, and of course, on the call, Matthew, Matt, I'm sorry, Hughes, Jonathan Hughes. Jonathan Hughes at Ascension St. Thomas have been really huge champions for this effort to get more pharmacists into primary care settings. And Ashley is going to be continuing to work on this with Jonathan and others in this next phase. So we're eager to keep that rolling. Anything, Jonathan or Ashley, you'd like to say about your efforts to build ambulatory pharmacy and primary care and practices working with us?
Jonathan, you have anything?
Oh, you're muted, Jonathan. And a lot of this has been about sharing best practices. And Jonathan's practice represents one of those really that's successfully, and Ballad Health has done tremendous work to really show others how we can engage ambulatory pharmacists in primary care.
Can you hear me now?
Yes.
We hear you.
Sorry about that. I was just saying we certainly appreciated the community that the Tennessee Heart Health Network has brought. Really grateful to have a lot of like-minded folks who are dedicated to not only seeing our patients here in Tennessee improve their cardiovascular heart health outcomes, but also bringing the many different disciplines and members of the team to the table, including our pharmacists. I'm really excited to have been able to collect some of the data that we weren't previously collecting, kind of spurred on by this Heart Health Network initiative. We saw some significant improvements in our hypertension control for our participating clinics as we more systematically started trying to connect patients with high blood pressures to our pharmacists. And I'm hopeful to see that the Tennessee Heart Health Network's been able to aggregate that data and hopefully show a statewide benefit to that pharmacist physician collaboration.
Wow, you said it so well, Jonathan. And, you know, I think that, yeah, I think we will be thrilled to see what the impact of this has been statewide. Just doing this work together, has it made a difference? I think, though, for those of us who've participated in some of these interventions and are in the boots on the ground doing the work, we know that some of this activity has made differences for our patients, and we'll look forward to seeing that in aggregate form. So let's see, I lost my presentation screen. There we go. Okay, so I'm going to jump ahead because I'm using up my time. I did want to say some of our practices are still working on getting their data feeds completed. That's incredibly important for our assessing the impact of this project, and for our, for future funding for this sort of effort. And we know that by working together to track and share our data and getting better at that, we can do better at moving these metrics that are so hard to move. So let me just encourage you, if you're the people on your team that are working on establishing your data feed, and I think most of you, your data feeds are established and ongoing, but wherever you are in that process, we want to continue to provide data back to you that is increasingly valuable in terms of those practice improvement reports, and be able to demonstrate to you the impact of some of the initiatives that you're undertaking. So continue your efforts there if you can. Many of you know we're rolling out the remote patient monitoring services in collaboration with Compwell. Annie Ninen on this call is our point person for that and is working with Ricky at Compwell. But feel free, if you're interested in that, having a turnkey approach that actually uses your Tennessee Population Health Data Network, that TN-PopNet data that you're already submitting, to help Compwell work with you to identify your highest risk patients and offer them that remote patient monitoring service. That is going to be moving forward over the next several years. So if you're interested in that service, reach out to Annie. And now I want to talk briefly about the Innovative Cardiovascular Health Program, which is our funding for the next 5 years. It's actually $6 million worth of funding, which is phenomenal, for the next 5 years to help us carry our work forward. And I think you've heard from me that this funding will help us continue to run our learning collaboratives, to do many of the things that we've been offering and supporting across the state over the last several years. But there's some key differences and a key new focus for the Innovative Cardiovascular Health Program. This new effort focuses explicitly on helping practices address social determinants of health. And their theory is that if we get better at identifying and addressing social determinants of health, particularly around things like food insecurity and transportation, that we're going to be able to do more to impact cardiovascular outcomes and disparities. And the CDC grant requires us to focus intensive effort in census tracts with very high hypertension prevalence in adults. And so it requires us to really we can work with practices across the state, but they want us to particularly focus on these practices. And many of you work for those practices that work in these census tracts or serve patients in the census tracts with the highest prevalence of hypertension. And where are these census tracts? It ends up there are about 40 census tracts across the state that meet this CDC criteria. So we're going to be particularly intensively focused in our social determinants of health work through the Heart Health Network on these census tracts. And interestingly, of those census tracts with very high prevalence of hypertension, which also have high prevalence of social determinants of health and have some of the worst cardiovascular outcomes in the state, of the 40 census tracts, about 30 of them are in Memphis. So for the CDC work, and you've already heard that's not all of our work, but for the CDC work, we're going to be focused very intensively on this social determinants of health work in Memphis with Christ Community Health Services, Regional 1, Church Health, in Jackson with CCHS, in Chattanooga with Erlanger and Health Force and some of the other safety net providers in that community, in Knoxville with UT Medical Center Knoxville, simply because those are where the census tracts are that CDC wants us to focus on. But frankly, all of us across the state are being encouraged to do more work in this social determinants of health area. Oh, and I do want to say, Jonathan, since I'm seeing you on my screen, there is a census tract in Nashville that meets the criteria. And so we are going to be doing our best to work with providers serving that census tract. I don't think it's a focus for your practice, but it is, but you may have some of those patients. So, and the point I want to make is this work around how we identify and address social determinants of health in primary care that the CDC wants us to have a particular focus on is something relevant to Ballad Health in East Tennessee. It's relevant to providers working in rural health areas. And our learning collaboratives are going to remain open to all our existing members. So, I just wanted to let you know, we will, in our learning collaboratives, continue some of our work on the existing intervention areas, but we're going to be moving to add a more intensive focus on social determinants of health and how we address and intervene on those. And those learning collaboratives will be open to all our existing members to participate in. And work with the other practices, because we know that even if you're not one of these census tracts, you are serving patients in need, and having to do some of that work in many cases. So here are the census tracts in Memphis. that we'll be particularly focused on? Here are the census tracts in in Jackson, Tennessee, and there are actually a couple of qualifying census tracts north of Jackson in the Humboldt area that we may work with providers there a little bit. Here are the census tracts in Chattanooga and some of the providers, key safety net providers there. And here is the one census tract in Knoxville, that East Knox. And we're excited that Cherokee Health Systems is going to be working with us in the Knoxville area as a new member of the Tennessee Heart Health Network. So what are the CDC strategies? Well, the first is to better use our existing data and increase use of EHRs and health information technology to report, monitor, and track clinical data, the same clinical data we're already tracking around hypertension control, diabetes control, smoking cessation counseling. They have an interest also in cholesterol treatment. So we'll also be have a little bit of a focus on, use of lipid-lowering therapies for eligible patients. And also use of EHRs and HIT to report on social determinants of health. So I'd like to do a, so we're already getting from some of our practices the social determinants of health data as part of the data feed that you provide to the TN-POPNet. We're going to be trying to increasingly help you use that data and feedback that data to practices. I'd love a kind of quick show of hands, if possible. How many of you, and you can raise your electronic hand, are currently collecting some social determinants of health data in your practice? I'm going to raise my hand for Regional One Health because we're doing a little bit there and we're trying to expand it. Jonathan, I see your hands up. That's great. Jennifer Logan, Jill Jones, I see your hands are up. Yeah, so we're eager to learn from you and hear from you about what are the questions you have about how to collect that data, how to use that data. Yeah, so just for starters, any burning questions as we get into helping you think about the collection and using that data to close the loop on social needs, any areas where you would particularly like to see our learning collaboratives focus in the next 5 years, but particularly in the next year, I'd say. Any problems you're thinking about struggling with regarding how you use that data or how you collect it?
I think the biggest challenge we've seen at ETSU is it's one more screener that we're asking somebody to fill out. As with every screener, how do we efficiently get that into the EHR? Because it's easiest to hand the patient a piece of paper to give them something to do while they wait in the waiting. But then that has to be transitioned into the EHR. And then how do you develop a workflow whereby if they're positive and they want assistance for whatever they answered positively to, how do we then get that person hooked up immediately if possible with our social workers? And then from there, we're on the Unite Us platform, which Ballad Health has made available free of charge for community partners, which is fantastic, and we do use it, but it's still kind of new, so a lot of people aren't really allowing electronic referrals, so that social worker is still having to pick up the phone and call, and So the tracking components that are built into that system aren't really being utilized to their fullest extent yet. So we've had, I think one clinic is doing the entire workflow right now. We've got others that are doing sort of bits and pieces of it. It's, we've never really gotten it rolled out completely just because of workflow and workforce challenges. I don't know that answers your question, but that's kind of where we are with it right now.
That's a fabulous answer, because I think you're in a similar spot to many of the practices that are, struggling with how to set up the workflows, et cetera. And I wonder, Jennifer, if you might be willing to consider, maybe in the second quarter of 2024, you and a colleague sharing at one of these learning collaboratives a bit about your experience, your early experience with the collection and making actionable of that data.
It would probably, I don't mind. It'd probably be best to get our social worker in Bristol. She's the one who's been kind of spearheading, trying to get this actually up and rolling in that clinic. So I would love to have her join. She would have more information than I do for sure.
That would be great if you would be willing just to suggest that to her, and Jennifer Ride, we might follow up with Jennifer Logan, just thinking about that, because I think right now we're at a point where just sharing experience is, I think, really helpful. And I'm going to go back to my slides. The other thing you see here is use of geomapping tools. The CDC grant has a major geomapping component, and we're going to be trying to provide geographic mapping information back to practices to help them and their patients find the social services that are closest to them. So we've got a major, we're going to have a major geomapping effort as part of this work for the CDC. We don't have a lot of time to talk about this now, but it may be a subject of future discussions. There are all these different screening tools that we're using for identifying SDOH. And personally, I really like the core 5 just because it's only 5, because this is a lot of burden to ask to have yet one more screening tool. And yet you want to get critical information about unmet social needs. Here's the core 5, my current favorite. Easy to do in the waiting room, but you have those issues of how do you get this information into the medical record. I think the one that TN-Care is really promoted is Prepare, the Prepare tool. But all of these tools are good, and finding out the one that works best for you, that's supported by your EHR, is part of the work around this. So the second major CDC strategy for the CDC grant is helping practices coordinate social care, and doing what we can to support increased use of HIT systems to support communication and coordination among care team members, to monitor and address hypertension and high cholesterol. Well, that's what we've been doing all, and I think of ETSU's work, closing the loop on patients who are uncontrolled in hypertension. Ascension St. Thomas's work, all Erlanger's work in this area. So this is something that the CDC wants to see us to continue to support. They have an emphasis here on increasing use of multidisciplinary care teams to address social services and report needs. And Jennifer alluded to that. You identify these needs, who's going to address them? who's going to help link people to services. So figuring out the workflows around that and who are the personnel, and increasing multidisciplinary partnerships. Those are partnerships with social service agencies. So we're going to be doing a lot at our upcoming learning collaboratives in 2024 to engage social service agencies who can help us understand how best link with them and link patients to their services. We talked about Jennifer talked about referring to needed services through Unite Us. We have some of our partners we know already who are using Aunt Bertha, for example. Christ Community Health Services is using findhelp.org. But this is a piece of the puzzle, but it's not all of the puzzle, right? We know that these electronic tools can give people a list of services, but getting that in their hands and helping make sure that we close the loop on social needs. So we'll be doing a lot of focus, I think, in the upcoming years on how to help practices close the loop on these referrals to critical social services. And you've already heard we're going to be trying particularly to help on this food insecurity business, helping these communities in greatest need get access, and people in those communities get access to healthful food, which is no easy thing. Who closes the loop? That's going to vary by the practice, but I think that's part of what we have to help practices think about, is who makes sure that loop's closed and does it in a friendly, patient-centered way that makes it easy for people to get the services they need to help them achieve better health. And the last CDC strategy is extending care into the community. So they're very about increasing use of CHWs or health coaches to extend clinical care. They're very interested in increasing use of self-monitoring of blood pressure, which can include remote patient monitoring. And they're very interested in increasing those community clinical links, which all of you are interested in, I know. So I'm just going to share one last piece around that business of extending care into the community. We've had a little experience with neighborhood health hubs in Memphis, deploying health coaches in freestanding locations, but using those health coaches in underserved neighborhoods to refer people into primary care, make sure they at least get screened and make sure their social needs are met, and provide health coaching. So Chattanooga is now thinking about opening a health hub that will work with its clinics, both Erlanger, SEMPA, and other clinics serving their most needy census tracts. So if this is a model you're interested in, reach out to us. We think we need more of these field workers, helping people get connected to care and supporting them in achieving their own health goals. So I think we do have ongoing opportunities to expand the primary care team. I see we're at the end of the hour and I'm at the end of my slides. I hope this is information that's been helpful and interesting to people. I'm going to stop sharing my screen. Any final questions or thoughts at the end of this learning collaborative?
I believe Dr. Bailey dropped off, so thank you all. We're at the top of the hour. If you have any questions, feel free to reach out to any of us, Pat, Alicia, or myself. And thank you for joining today.
Thank